my name's Ellie and today I'm going to be doing my EJV OSCE. So we use EJVs in patients that are critically ill, patients that need a high flow rate, or patients where we can't gain peripheral IV access. So today I've got my correct PPE on, my gloves, glasses and my correct uniform on. And firstly we're going to ask our patient for consent. So we want to ask our patient, is it okay to pop a needle in the neck, and then we're going to remove the needle and just leave a little plastic tube so we can insert drugs and fluid. In the setting of if the patient is unconscious or if the patient is in cardiac arrest, obviously consent we can't ask, so we assume that consent is implied. So when we are doing our EJV, we firstly want to distend the jugular vein so that we can see it and palpate it. So we can do this in multiple ways. Firstly, we can turn the patient's head on a 45-degree angle and we can tamponade supraclavicular. This will hopefully distend the jugular vein, we'll be able to see it, and we'll also be able to palpate it. If that doesn't work, we can lay the patient supine and elevate the legs. We can put pressure on the liver, or if the patient is conscious, we can get them to bear down or breathe into a syringe. Once we've seen the jugular vein and it's become distended, we want to make sure that all our gear is ready. So we've got our alcohol swab to ensure that we use the aseptic technique and we're keeping the site sanitary and clean. We've got our cannula attached to our syringe, which has 3 ml of sodium chloride in it, 0.9%. For the purpose of the video, we're only using a 20 gauge needle to ensure we don't damage the mannequin too much. However, in an actual patient, we'd use a much larger gauge needle. We've got our PosiFlush, which is 0.9% sodium chloride. It's 10 ml and it expires in September 2021. This would be, both of these salines would be drug checked both by myself and my crew partner. We've also got our Lua to ensure that any backlog of blood is stopped. We've got our Tegaderm to secure our line, and then we've got our gauze to clean up any blood. We've got our sharps container for correct sharps practice. Awesome. So when we're starting, we want to grab our alcohol swab out. And we want to use the aseptic technique. So we're going to start from the inside, the side of the injection. We're going to move outwards, making sure to not re-go over the same site because we don't want to dirty it. And then we're going to let that dry for a minute. In the meantime, we're going to get our cannula and syringe out. Our syringe is attached just to ensure that we don't cause an air emboli because of the high velocity of the jugular vein. We don't want to suck in some air and cause an air emboli. So I've got my fingers so that I can have my pinky so that I can aspirate to ensure that we are in the jugular vein, and so that I can get a good insertion. So I want to warn my crew and myself to sharps out. I'm then going to tamponade at the bottom of the vein and traction at the side at the top, making sure we're not touching it. And I'm going to go on the top half of the vein, sharp scratch, and I'm inserting it at 15 to 20 degrees until I believe I'm in the vein. Once I think that I'm in, I'm keeping my hand nice and still. I'm aspirating. I can see blood. I'm then going to shimmy my fingers forward. I'm going to flatten it, advance 2 to 3 more mils. I'm going to advance the catheter all the way, keeping my hand nice and still. I'm then going to continue to tamponade. I'm going to hold it, sharps out, sharps in the sharps container. I'm going to grab my Lua. Once I've attached my Lua, I don't need to tamponade anymore. Hold on. And then I'm going to secure my line. But I still want to make sure that I can still see the insertion. And then I want to ensure that it's clear and patent line. So I'm going to attach my PosiFlush. And then I'm going to aspirate just to ensure that I'm still in the vein. Yeah. And then I'm just going to gently push it through. Up to 5 mils. Take that one off. So now that I know that my line is clear and patent, I can go and secure the rest of my line. So I'm going to grab my tegaderm and going to attach it. So we insert it at the top half of the vein because we want to make sure that we don't accidentally puncture the pleural cavity, causing a pneumothorax. And we also want to keep our hands nice and steady when we're inserting and when we are pushing the cannula forward, because we don't want to shave off a piece of the plastic, causing a plastic emboli. So I can still see my line, and I'm going to remove this. And with this piece, I'm going to write the time, the date, and the gauge of the needle that we've used. I'm going to pop that up the top. I'm going to grab my other piece of tape, just make sure that our line is nice and secure. Once we've done that, we've now got a line in the external jugular vein, and we can insert drugs here, and we can also attach it to a fluid bag.